completion of surgery, and transfer the patient to either the post-anesthesia care unit, PACU, the same-day surgery unit, or intensive care unit mark the beginning of postoperative period. Patients are discharged from these areas when they are stable and have met specific discharge criteria. Many patients can be discharged home shortly after surgery is completed. They are observed and monitored until discharge criteria are met and are then discharged. Some patients move from the specialized nursing care in PACU to a hospital inpatient floor or ICU for additional nursing care. The postoperative period continues after the patient's condition is stabilized, as well as after the patient is discharged from the ambulatory surgery facility or hospital. The purpose of the post-anesthesia care unit is the ongoing evaluation and stabilization of patients to anticipate, prevent, and manage complications after surgery. The PACU is usually located close to the surgical suite for ease of access and patient transfer. The unit is usually a large room to provide direct observation of all patients and easy to access to supplies and emergency equipment. The patients are divided into individual cubicles. Each cubicle has equipment to monitor and care for the patient, such as oxygen, suction equipment, cardiac monitors, pulse oximetry, airway equipment, and emergency drugs. After the surgery is completed, the circulating nurse and the anesthesia provider accompany the patient to PACU. The national patient safety goals require that the anesthesia provider and the circulating nurse give the PACU nurse a verbal hands-off report to communicate the patient's condition and care needs. The PACU nurse is skilled in the care of patients with multiple medical and surgical problems immediately after a surgical procedure. This area requires in-depth knowledge of anatomy and physiology, anesthetic agents, pharmacology, pain management, extubation, surgical procedures, and advanced cardiac life support. The PACU nurse is skilled in assessment and can make quick decisions if emergencies or complications occur. The patient is monitored closely. The anesthesia provider and surgeon are consulted as needed. The PACU nurse uses the surgical team's report to plan the care for the patient. After receiving report and assessing the patient, the PACU nurse will review the medical record for information about the patient's history, pre-surgical condition, and emotional status. The assessment data the PACU nurse collects includes level of consciousness, temperature, pulse, respirations, oxygen saturation, and blood pressure. The nurse examines the surgical area for bleeding. Vital signs are monitored according to the facility's policy, the patient's condition warrants, and as prescribed by the surgeon. Once the patient is discharged from PACU, vital signs are often measured every 15 minutes for 4 times, every 30 minutes for 4 times, every hour for 4 times, and then every 4 hours for 24 to 48 hours if the patient's condition is stable. The healthcare team develops the patient's readiness for discharge from PACU. Most facilities have a post-anesthesia recovery score tool that is utilized. The tool rates activity level, respiration, circulation, level of consciousness, and oxygen saturation as a rule. Other criteria for discharge from the PACU include stable vital signs, normal body temperature, no overt bleeding, return of gag, cough, and swallow reflexes, the ability to take liquids, and adequate urine output. Assessment continues from the PACU to the intensive care unit or the medical surgical unit. If the patient is to be discharged from the PACU to home, assessment is continued by home care nurses or the patient's family members after health care teaching. During the postoperative period, all patients remain at risk for pneumonia, shock, cardiac arrest, respiratory arrest, venous thromboembolism, VTE, and GI bleeding. These serious complications can be prevented or the consequences reduced with coordinated care, nursing observations, and interventions are part of the critical rescue management for patient safety and quality care as defined by the National Patient Safety Goals to reduce the risk of adverse patient outcomes after surgery. When the patient is admitted to PACU, immediately assess for a patent airway and an adequate gas exchange. An artificial airway, such as an endotracheal tube, a nasal trumpet, or an oral airway, may be in place. If the patient is receiving oxygen, document the delivery device and the concentration or liter flow of the oxygen. Continuously monitor pulse oximetry for oxygen saturation. The SpO2 should be above 95% or at the patient's pre-surgery baseline. Assess the pattern and depth of breathing to determine adequacy of gas exchange. A respiratory rate less than 10 breaths per minute may indicate anesthetic or opioid analgesic induced respiratory depression. Rapid, shallow respirations may signal shock, cardiac problems, increased metabolic rate, or pain. Listen to the lungs over all lung fields to assess breath sounds. Also check symmetry of breath sounds and chest wall movement. Perform ongoing inspection of the chest wall for accessory muscle use, sternal retractions, diaphragmatic breathing. These signs could indicate an excessive anesthetic effect, airway obstruction, or paralysis which could result in hypoxia. Listen for snoring or stridor. Snoring and stridor occur with airway obstruction resulting from tracheal or laryngeal spasm or edema, mucus in the airways, or blockage of the airway from edema or tongue relaxation. When neuromuscular agents are retained, the patient has muscle weakness, which could impair gas exchange. Indicators of muscle weakness include the inability to maintain a head lift, weak hand grasp, and an abdominal breathing pattern. Throughout the initial postoperative period and for at least the first 24 hours after surgery, the patient should be continually assessed for respiratory depression and hypoxemia. Vital signs and heart sounds are assessed on admission to the PACU and then at least every 15 minutes until the patient's condition is stable. Decreased blood pressure and pulse pressure and abnormal heart sounds indicate possible cardiac depression, fluid volume deficit, shock, hemorrhage, or the effects of the drugs given before or during surgery. Bradycardia could indicate an anesthesia effect, hypothermia. Older patients are at risk for hypothermia because of age-related changes in the hypothalamus, low levels of body fat, and coolness of the OR suite. An increased pulse rate could indicate hemorrhage, shock, or pain. Cardiac monitoring is generally maintained until the patient is discharged from PACU. In assessing vital signs of a patient who is not being monitored continuously, compare the rate, rhythm, and quality of peripheral pulse, such as the radial pulse. A pulse deficit could indicate a dysrhythmia. Peripheral vascular assessment needs to be performed because anesthesia and positioning during surgery may impair peripheral circulation and contribute to venous thromboembolism, especially deep vein thrombosis. Compare the distal pulses on both feet for the quality of pulsation. Observe the color, the temperature of extremities, evaluate sensation, and determine the speed of capillary refill. Palpable pedal pulses indicate adequate circulation and perfusion of the legs. Assess the feet and the legs for redness, pain, warmth, and swelling, which may occur with DVT. Cerebral functioning and level of consciousness or awareness must be assessed in all patients who have received general anesthesia or any type of sedation. Observe for lethargy, restlessness, or irritability, and test coherence and orientation. Determine awareness by observing responses to calling the patient's name, touching the patient, and giving simple commands such as open your eyes and take a deep breath. Determine the degree of orientation to person, place, and time by asking the conscious patient to answer questions such as what is your name? Where are you? And what day is it? Compare the patient's baseline neurologic status with the findings after surgery. Patients who have altered cerebral functioning before surgery because of another condition usually continue to have alteration after surgery. Motor and function and sensory function are assessed for all patients who receive general or regional anesthesia. General anesthesia depresses all voluntary motor function. Regional anesthesia alters the motor and sensory function of only a part of the body. Motor and sensory assessment are very important after epidural or spinal anesthesia. Evaluate motor function by asking the patient to move each extremity. The patient who had epidural or spinal anesthesia remains in the PACU until sensory function and voluntary motor movement of the legs has returned. Also assess strength of each limb and compare results on both sides. Fasting before and during surgery, the loss of fluid during the procedure, and the type and amount of blood or fluid given affect the patient's fluid and electrolyte balance after surgery. Fluid volume deficit or overload may occur after surgery. Sodium, potassium, chloride, and calcium imbalances also may result, as many changes in other electrolyte levels. Fluid and electrolyte imbalances occur more often in older, debilitated patients and in those with health problems such as diabetes mellitus, Crohn's disease, or heart failure. Intake and output measurement is part of the operative record and is reported by the circulating nurse to PACU nurse. Record any intake or output, including IV fluid intake, vomitus, urine, wound drainage, and nasogastric tube drainage. You must know the total intake and output for both the OR and the PACU to assess fluid balance accurately and to compare the 24-hour intake and output record. Hydration status is assessed in PACU. To determine hydration status, inspect the color and moisture of mucous membranes, the turgor, texture, and tenting of the skin, the amount of drainage on dressings, and the presence of axillary sweat. Measure and compare total output with total intake to identify a possible fluid balance. Consider insensible loss, such as sweat, when reviewing total output. Acid-base balance is affected by the patient's respiratory status before and during surgery, metabolic changes during surgery, and losses of acid or bases in drainage. For example, NG tube drainage or vomitus causes a loss of hydrochloric acid and leads to metabolic alkalosis. Control of urination may return immediately after surgery or may not return for hours after general or regional anesthesia. The effects of preoperative drugs, anesthetic agents, or manipulation during surgery can cause urine retention. Assess for urine retention by inspecting and palpation of the lower abdomen for bladder distension or by use of a bladder scanner. Urinary retention is common after surgery and may require intervention such as intermittent catheterization to empty the bladder. When the patient has an indwelling catheter, assess the urine for color, clarity, and amount. If the patient is voiding, assess the frequency, amount per void, and any symptoms. Urine output should be close to total intake for a 24-hour period. Consider other sources of output, such as sweat, vomitus, or diarrhea stools. Report a urine output of less than 30 milliliters per hour to the physician. Decreased urine output may indicate hypovolemia or renal complications. Postoperative nausea and vomiting are among the most common reactions after surgery. About 30% of patients who receive general anesthesia has some form of GI upset within the first 24 hours after surgery. However, some patients are more at risk than others. Patients with a history of motion sickness are more likely to develop nausea and vomiting after surgery. Obese patients may be at risk because many anesthetics are retained by fat cells and remain in the body longer. Postoperative nausea and vomiting can stress and irritate abdominal and GI wounds, increased intracranial pressure in patients who have had eye surgery, and increase the risk of aspiration. Intestinal peristalsis may be delayed because of prolonged anesthesia time, the amount of bowel handling during surgery, and opioid analgesic use. Patients who are recovering from abdominal surgery often have decreased or no peristalsis for at least 24 hours. This problem may persist for several days for those who have had GI surgery. Listen for bowel sounds in all four quadrants and at the umbilicus. If NG suction is being used, turn off the suction before listening to prevent mistaking the sounds of suction for bowel sounds. The presence of active bowel usually indicates return of peristalsis. However, the absence of bowel sounds does not confirm a lack of peristalsis. The best indicator of intestinal activity is the passage of flatus or stool. Abdominal surgery and the use of opioid analgesics reduced intestinal peristalsis after surgery. These problems increase the risk for prolonged nausea and vomiting after surgery. Preventative drug therapy is effective in reducing the incidence. Drugs often used are ondansetron, a serotonin antagonist, and meclizine, a sedating H1 histamine antagonist. A nasogastric NG tube may be inserted during surgery to decompress and drain the stomach to promote GI rest and to allow the lower GI tract to heal. It may also be used to monitor any gastric bleeding and to prevent intestinal obstruction. One of the most common tubes used is the Salem sump. The Salem sump, which is illustrated on the right side of this PowerPoint slide, is a double lumen tube with an air vent to keep the tube from grabbing the gastric mucosa. This feature allows easy drainage of the stomach and prevents mucosal damage. Less commonly used is the Levine or the Levine tube. That's the left illustration on this slide, which is a single lumen tube with no air vent. To promote drainage, suction, usually low, is applied to the NG tube. Suction is either continuous, recommended for the Salem sump, or intermediate. Record the color consistency and the amount of NG drainage every 8 hours. In some instances, an occult blood test may be performed. Normal NG drainage is greenish yellow. Red drainage fluid indicates active bleeding, and brown liquid or drainage with a coffee ground appearance indicates old bleeding. Assess that the NG is securely taped to the nose and note any skin irritation. Assess the patient for complications related to NG tube use, such as fluid and electrolyte imbalances, aspiration, and Nares discomfort. To prevent aspiration, check the tube placement every 4 to 8 hours and before instilling any liquid in the tube. Fluid and electrolyte imbalances can result from NG drainage and tube irrigation with water instead of saline. Imbalances include fluid volume deficit, hypokalemia, hyponatremia, hypochloremia, and metabolic alkalosis. The clean surgical wound heals at the skin level in about 2 weeks in the absence of trauma, connective tissue disease, malnutrition, or the use of some drugs such as steroids. Smokers and patients who are older, obese, or diabetic, or whose immunity is reduced have delayed wound healing. Complete healing of all tissue layers within the surgical wound may take up to 6 months to 2 years. During the first few days of normal wound healing, the incised tissue regains blood supply and begins to bind together. Fibrin and a thin layer of epithelial cells seal the incision. After 1 to 4 days, epithelial cells continue growing in fibrin and strands of collagen begin to fill in the wound gaps. This process continues for 2 to 3 weeks. When the patient is an inpatient, the surgeon is usually the one that removes the original dressing on the first or second day after surgery. Assess the wound on a regular basis, at least every 8 hours for redness, increased warmth, swelling, tenderness, or pain, and the type and amount of drainage. Some drainage, changing from sanguineous to serosanguineous to serous, is normal during the first few days. Crusting on the incision line is normal, as is a pink color to the line itself, which is caused by inflammation from the surgical procedure. Slight swelling under the sutures or staples is also normal. Redness or swelling of or around the incision line, excessive tenderness or pain or palpation, and purulent or odorous drainage indicate wound infection and must be reported to the surgeon. Serous sanguineous drainage continuing beyond the 5th day after surgery or increasing amount instead of a decreasing alerts you to the possibility of dehiscence, and the surgeon should be notified. Impaired wound healing may be caused by infection, distension from edema or paralytic ileus, stress at the surgical site, and health problems that cause delayed wound healing, such as diabetes. Wound dehiscence is a partial or complete separation of the outer wound layers. Evisceration is a total separation of all wound layers and protrusion of internal organs through the open wound. Both of these problems occur most often between the 5th and the 10th days after surgery. Wound separation occurs more often in obese patients and those with diabetes, immune deficiency, or malnutrition, or who are on steroids. Dehiscence or evisceration may follow forceful coughing, vomiting, or straining, and when not splinting the surgical site during movement. The patient may say, "Something gave way," or "I feel as I just split open." Assess all dressings, including cast and elastic bandages, for bleeding or drainage. Check the dressing for drainage and record amount, color, consistency, and odor. If drainage is present on a dressing or cast, monitor its progression by outlining it with a pen or Sharpie and indicating date and time. Check the area underneath the patient also, because drainage or blood may leak from the side of the dressing and not appear on the dressing itself. Ensure that the dressing does not restrict circulation or sensation. The problem is most likely to occur when dressings are tight or completely encircle an arm or a leg. Chest dressings that are too tight or that encircle the chest can restrict breathing. The surgeon inserts a drain into or close to the wound if more than a minimal amount of drainage is expected. A Penrose drain, a single lumen soft open latex tube, is a gravity type drain under the dressing. Drainage on the dressing is expected with open drain, but it is not expected with closed drainage systems. Assess closed suction drains such as a Hemovac and a Jackson Pratt drains for maintenance of suction. Specialty drains such as a T-tube may be placed for a specific drainage purpose. For example, a T-tube drains bile after a cholecystectomy or the removal of a gallbladder. Montgomery straps may be used when frequent dressing changes are anticipated. They help prevent skin irritation from frequent tape removal. The patient almost always has pain or discomfort after surgery. Pain is a subjective experience and may be more intense than the healthcare professional can appreciate. Pain after surgery is related to the surgical wound, tissue manipulation, drains, positioning during surgery, presence of an endotracheal tube, and the patient's experience with pain. In assessing the patient's discomfort and need for medication, consider the type, extent, and length of the surgical procedure. Assess for physical and emotional signs of pain, such as increased pulse and blood pressure, increased respiratory rate, profuse sweating, restlessness, confusion, wincing, moaning, and crying. When possible, ask the patient to rate the pain before and after drugs are given. Plan the patient's activities around the timing of analgesia to improve mobility. Pain assessment is started by the PACU nurse. After the patient is transferred from the PACU, the medical surgical nurse continues to assess the patient's comfort level. Pain usually reaches its peak on the second day after surgery, when the patient is more awake and more active, and anesthetic agents and drugs given during surgery have been excreted from the body. Laboratory tests are performed after surgery to monitor for complications. Tests are based on surgical procedure, the patient's medical history, and clinical manifestations after surgery. Common tests include analysis of electrolytes and a complete blood count. A change in the laboratory tests often occurs during the first 24 to 48 hours after surgery because of blood and fluid loss and the body's reaction to the surgical procedure. Fluid loss with minimal blood loss may cause a hemoconcentration of laboratory values. Such test results are reported as increased but represent a concentrated normal value. An indication of infection is an increase in the band cells, immature neutrophils, in the white blood cell differential count. This increase is termed a left shift or shift to the left, also called bandemia. The source of the infection may be the respiratory system, urinary tract, surgical wound, or even the IV site. Obtain specimens for culture and sensitivity testing and monitor the culture reports at 24, 48, and 72 hours. Notify the surgeon of positive culture results. Arterial blood gas tests may be needed for patients who have respiratory or cardiac disease, those undergoing mechanical ventilation after surgery, and those who have had chest surgery. Review ABG results, notify the surgeon of any acid-base imbalance or hypoxemia. Urine and kidney laboratory tests also may be obtained, such as a urinalysis, urine electrolyte levels, or serum creatinine levels. Other laboratory tests depend on diagnosis, type of surgical procedure, and other health problems. Examples are a serum amylase level for patients who have had pancreatic surgery and blood glucose level for a patient with diabetes mellitus. Listed on this slide are probably your top 3 patient problems for a postoperative patient. On the next few slides, each of these problems and the nursing responsibilities will be discussed in more detail. In preventing hypoxemia, as a nurse, we want to plan for some expected outcomes. We would expect the patient to attain and maintain optimal lung expansion and breathing patterns after surgery, as would be indicated by partial pressure arterial oxygen within normal range, or partial pressure arterial carbon dioxide within normal range, and of course oxygen saturation values within normal range. After assessing the airway, you may need to insert an oral airway if the patient does not already have one. The oral airway pulls the tongue forward and holds it down to prevent obstruction. If the patient had oral surgery or has clenched teeth, a large tongue, or upper airway obstruction, insert a nasal cannula. or a nasal trumpet to keep the airway open. Keep manual resuscitation bag and emergency equipment for intubation and a possible emergency tracheostomy nearby. Monitor oxygen saturation with pulse oximetry at least every hour or more often according to the patient's conditions. Patient who normally has a low PaO2, such as those with lung disease or older adults, are at higher risk for hypoxemia. An older adult is usually prescribed low-dose oxygen for the first 12 to 24 hours after surgery to reduce confusion from anesthesia and sedation. A patient who received moderate sedation with a benzodiazepine, such as Versed, may be overly sedated or have respiratory depression sufficient to need a reversal with Romazicon. Hypothermia after surgery causes shivering that increases oxygen demand and can induce hypoxemia. In the PACU, immediately position the patient in a semi-Fowler's position unless contraindicated. If the patient cannot have their head of the bed raised, either place the patient in a side-lying position or turn their head to the side to prevent aspiration. Hypoxemia is prevented and managed with oxygen therapy. Apply oxygen by face tent, nasal cannula, or mask to eliminate inhaled anesthetic agents. Increase oxygen levels, raise the level of consciousness, and reduce confusion. After the patient is fully reactive, raise their head of the bed to promote respiratory function. As soon as the patient is awake enough to follow commands, urge the patient to cough, use incentive spirometry, and take deep breaths. Remind the patient to continue these activities every 1 to 2 hours. Assist the patient out of bed to ambulate as soon as possible to help promote lung expansion and remove secretions. Even when the patient has had extensive surgery, the expectation is to get them ambulating. If this is not possible, assist the patient to turn at least every 2 hours and ensure that the breathing exercises are performed. Early ambulation reduces the risk for pulmonary complications, especially after abdominal, pelvic, or spinal surgery. The patient is expected to have incision healing without wound complications as indicated by wound edges remain together and there is no purulent drainage, induration, or redness in or around the incision. Wound care includes reinforcing the dressing, changing the dressing, assessing wound healing and infection, and caring for drains, including emptying drainage containers, reservoirs, measuring drainage, and documenting drainage features. Emphasize the importance of early, deep breathing exercises to prevent forceful coughing. Encourage hip flexion when the patient is in the supine position to reduce tension on a chest or abdominal wound. Remind the patient to always splint the incision when coughing. The surgeon usually performs the first dressing change to assess the wound, remove any packing, and advance or remove drains. Before the first dressing change, reinforce the dressing by adding more dressing material if it becomes wet with drainage. Document the added material as well as the color, type, amount, and odor of drainage fluid and time of observation. After removal of the dressing, the surgeon may leave the suture or staple line open to air, which allows for easy assessment of the wound and early detection of poor wound edge adherence, drainage, swelling, or redness. A draining wound is always covered. Skin sutures or staples are usually removed 5 to 10 days after surgery. The incision may be secured with steri-strips. Drains provide an exit route for air, blood, and bile. Drains also help prevent deep infections and abscess formation during healing. The Penrose drain is placed into the external aspect of the incision and drains directly onto the dressing and skin around the incision. Jackson Pratt and Hemovac drains are two self-contained drainage systems that drain wounds directly through a tube via gravity and vacuum. These drains are sutured in place usually. Record the amount and color of drainage during every nursing shift or more often if prescribed. After the emptying and compressing the reservoir to restore suction, secure the drain to the patient's gown to prevent pooling and stress on the surgical wound. Wound infection is a major complication after surgery. It usually results from contamination during surgery or a preoperative infection or a patient who is debilitated or immunosuppressed. Wounds that become infected are treated with dressing changes and systemic antibiotic therapy. Depending on the surgeon's orders, you irrigate a wound with normal saline, hydrogen peroxide, or even providone iodine. Loosely pack it with a solution-soaked gauze and then cover it with a dry, sterile dressing. Wet to dry dressing changes may be done 1 to 3 times a day. The packing promotes healing within the wound and debridement as the wound heals. If dehiscence occurs, apply a sterile, non-adherent, or saline-soaked dressing to the wound and call the surgeon. Instruct the patient to bend their knees and to avoid coughing. A wound that becomes infected dehisces by itself, or if it may be opened by the surgeon through an incision and drainage procedure. An evisceration is a surgical emergency. Call for help. Stay with the patient. Cover the wound with a dressing pre-moistened with normal saline. Place the patient in a supine position with hips and knees bent. Raise the head of the bed 15 to 20 degrees. Take vital signs. Provide support and reassurance to the patient. Continue assessing the patient, including vital signs, every 5 to 10 minutes until the surgeon arrives. Keep dressings continually moist with saline. Patients also are at risk for developing pressure ulcers from positioning during surgery, prolonged contact with damp, surgical linens, and contact with unpadded surfaces. Pressure ulcers acquired during the surgical period increases length of stay and the risk for complications. The postoperative patient is expected to attain or maintain optimal comfort levels. Indicators include reporting the pain is controlled or absence of any physiologic indicators of acute pain or absence of facial grimacing, teeth clenching, or and willingness to move and participate in self-care. Pain management after surgery includes drug therapy and other methods of management such as positioning, massaging, relaxation techniques, and diversion. Often the patient has better pain relief from a combination of approaches. The patient who has optimal pain control is better able to cooperate with therapies and exercises to prevent complication and promote rehabilitation. The use of opiates or other analgesics for pain management may mask or increase the severity of symptoms of an anesthesia reaction. Therefore, give these drugs with caution, especially in the PACU when the patient's condition is not stable. Assess for hypotension, respiratory depression, and other side effects. Within 5 to 10 minutes of administering IV injections of opioids, assess the effectiveness of the drug in relieving pain. Opioid analgesics are given during the first 24 to 48 hours after surgery to control acute pain. Around-the-clock scheduling is much more effective than on-demand scheduling because more constant blood level of the opioid is achieved. Patient-controlled analgesia, PCA, by IV infusion or intermittent pump, or epidural analgesia are often used for better pain control. In PCA, the patient adjusts the dosage of the analgesic based on their pain level and response to the drug. This method allows more consistent pain relief and more control by the patient. The maximum dose per hour is locked into the pump so that the patient cannot accidentally overdose. Epidural analgesia can be given intermittently by the anesthesia care provider or by continuous infusion through an epidural catheter left in place after epidural analgesia. Take care not to overmedicate or undermedicate. Complications from use of opioid analgesics include respiratory depression, hypotension, nausea, vomiting, and constipation. And opioid antagonists, such as Narcan, may be needed to reverse the acute effects of opioid depression. As recovery progresses, reduce the dosages and frequency of pain drugs. Drugs are changed from injectable or PCA to oral pain drugs. Non-opioid analgesics such as acetaminophen and NSAIDs such as Motrin are used alone or with opioid analgesics. Provide comfort measures that may lower the amount of pain drug needed. These measures, such as positioning, massage, relaxation, and diversional techniques, reduce anxiety and allow the patient to relax and rest. Many patients are discharged after a brief hospital stay or directly from the PACU to home. Because of the shortened length of stays, discharge planning, teaching, and referral begin before surgery and continue after surgery. If the patient is discharged directly to home, assess information about the home environment for safety, cleanliness, and availability of caregivers. The teaching plan for a patient and family after surgery should include prevention of infection, care and assessment of the surgical wound, management of drains and catheters, nutritional therapy, pain management, drug therapy, progression to increase activity, follow-up contact information, including telephone number of doctors. If dressing changes and drain care are needed, instruct the patient and family members the importance of proper hand washing to prevent infection. Explain and demonstrate wound care to the patient and family. A diet high in protein, calories, and vitamin C promotes wound healing. Supplemental vitamin C, iron, zinc, and other vitamins are often prescribed after surgery to aid in wound healing and red blood cell formation. Teach the patient about drugs for pain, especially about the proper dosage and frequency. Instruct the patient to notify the surgeon if pain is not controlled or if pain suddenly increases. If antibiotics or other drugs are prescribed, stress the importance of completing the entire prescription. Surgery stresses the body. Time and rest are needed for healing. Teach the patient to increase activity level slowly, rest often, and avoid straining the wound or surrounding area.